we get messages from people and wanting to talk about certain things on lives.
Absolutely.
And we recently got one from a friend of ours, Advo, and I'm just trying to find Advo so we can add her on the screen because, and of course, I'm not seeing.
Oh no, she's hiding.
Yep, she's hiding. To talk about, Advo, do me a favor, send me a request so I can get you up here. Talk about Painsomnia, because unfortunately, Karen's going through that as well.
Yeah.
There we go. Well, I'll pause as she joins in. Hey, lady.
Hey guys, good to be here.
We are glad you were here, and thank you for bringing this topic up, because
Yes.
the more you brought it up and the more people we've been talking to in the last week or so, the more people in the visible community are dealing with Painsomnia. And so maybe we can come up with ideas as a team, as a community, to help everybody out with this. That's what I love about the invisible community, right? Y'all know I'm a definition guy, so I had to give invisible a definition. And just simply, to me, people with varied diagnoses coming together to share lived experiences so that others can be more successful. And tonight would be a perfect example of that if we can do this. By throwing out your suggestions and how you deal with Painsomnia, whether it's something that works a little or a lot, or something that doesn't work, because like I said in the video I did today, what doesn't work for you may work for me, right? And what may work for me may not work for you. So let's throw also everything, everything, including the kitchen sink if we need to, right? Though I wouldn't recommend beating ourselves over the head with the kitchen sink. Well, there are times when I would say, look at this, I come prepared tonight. Even typed tonight. Can you believe it? It's the power of copy and paste, let me tell you.
Feel underprepared.
Don't.
Like I'm back in school.
Don't feel underprepared. But this is a pattern. This is something that's important to me because I'm dealing with it. I'm living with it.
Yeah.
I'm lucky if I can fall asleep at 2. I'm lucky.
Oh wow.
Sometimes it's 3, sometimes it's 4. Valerie is fighting it to where she'll fall asleep around 10 o'clock at night, but be up at 1 and be up the rest of the day.
Yeah.
So it's real. And that gets into, we'll discuss it later, it kills me that Painsomnia, or a definition. I think your doctor ended up diagnosing you with insomnia and then put pain in there somehow or another.
My doctor actually put on my chart insomnia due to medical condition. It's a code that the WHO uses. So that's the closest thing I've ever seen to Painsomnia being put on a chart. But I had to pretty much bang over their head that I'm not sleeping.
And see, and that's as we get into it, I want to talk about this as well. Doctors love to bill for things. Why isn't there a billing code for Painsomnia? Right. It's like I've found on all this research, from the Tylenol headache medicine website to the NIH. They all say it was just a term coined on social media from the pain community to describe not sleeping because of pain.
Yeah.
And by not having a medical official diagnosis, you don't have to word it Painsomnia, right? But I think something better than insomnia due to pain tells me that we're on our own. And as a community, we need to try to help figure things out to approach, either to live with it or approach our medical team. So what is definition? Because I'm the definition guy. How about this? It's the sensation of pain, aching, burning, tingling, stimulates the nerves, which activate the brain. And as a result, people can't relax and are kept awake by pain and anxiety. Because sleep heals the body, Painsomnia makes chronic illnesses worse and hinder recovery from certain experiences, including operations.
Absolutely.
Does that sound good?
Yeah. That nailed it. Round head.
So we can agree on a definition of what we're talking about tonight.
Yeah.
So see, definitions are like part of my undiagnosed ADHD stuff. I don't know what it is. I don't.
Hey, that's fine.
But it helps my brain. If I know what it means, it helps me to address it.
I understand.
So obviously I did research, right? And I read a lot this week, and I used chat GPT stuff, AI, to help me figure out what reports and studies were saying and stuff like that. And here's what it boiled down to, in my opinion. Nothing in these studies.
Wow, you're so prepared. My gosh.
Nothing in these studies.
I'm with Amy now. Mine are just wrote down. Go ahead.
I'm sorry. Nothing in these studies, or
no, you're not. Go ahead.
Yeah, I'm not. And what you can read and research is anything that as a chronic illness, chronic pain, mental health person, are things that you probably haven't tried.
Yeah.
All of their suggestions, right? Create a routine, which can be, as tough as it is, I think a lot of us invisibles have routines. I know I do. Yeah, I mean, to the best of our abilities, right? But I know I try to get physical stuff done in the morning, right? And because I know in the afternoon it's going to be worse. I try to do certain things in a certain way, because if the pain's really bad for me, it's like muscle memory takes over, and then the routine kind of carries itself. So create a routine. Avoid electronics before bed. Create a relaxing bedtime routine. Make your bed comfortable. I love this one. Take sleep assisting aids like melatonin or Tylenol PM. Tylenol PM website, they push their own stuff pretty bad.
Right.
Though I tell you, if you go to the Tylenol website, their information is footnoted like crazy. It's actually backed up. A lot of it, minus the advertising, is backed up with a lot of good science. So we've defined it. We've realized that the medical world is kind of leaving us on our own to develop our own type of solutions, right? So as invisibles, we tend to get creative and try to find different things that work for us. So before we get into that, your thoughts, Amy, because I know that I'm going to spill a little tea today, and I hope this doesn't embarrass you, but when I got a message from you earlier, you're like, it was like 11 o'clock. You're like, I'm going to take some NyQuil because I haven't been sleeping. 11 o'clock in the morning, right?
Yeah.
Taking NyQuil to get some sleep because you haven't been able to sleep, right?
Mm-hmm. Yeah,
And
I mean, and like, does it, I wouldn't say NyQuil knocks me out, but it does. I'm not giving medical advice. Don't do what I do, but I probably take more than I'm supposed to. And so it does help knock me out a little bit because I do feel like I'm starting to get a cold. But it's like, I have been up for almost 20 hours at that point. And I was like, it is 11 o'clock in the afternoon. I am taking this NyQuil and I am going to try and sleep for a moment because I am desperate to get any type of little bit of rest that I absolutely can.
Yeah, well, you know,
I'm the only one out there.
No, you're not. You and I were joking, even really before the topic of Painsomnia came up tonight, that I would love, and I can't believe hospitals and doctors don't offer this, I would love to go check into the hospital for 7 days and have them, as soon as I walk in, put me in a little gurney bed and then stick an IV in me and knock me out.
Yeah.
And then do the whole catheter thing, do like liquid diet to me, whatever, and just knock me out for 7 days straight.
Yeah.
Just 7 days.
Yeah. I had this conversation, I don't know if Jennifer's here tonight, but we were talking and I was like, I want to be rich, not because I want to buy things or go on expensive vacations, but you know, sometimes I just want to have a doctor come to my house and just give me some really good things and knock me out for a couple hours. Like, and I'm listening, we're not going to do the whole Michael Jackson thing.
Yeah.
We're not going to go that far. But, you know, just like when you're desperate and you haven't slept in weeks and you're like, can I just have somebody come to my house and knock me out for like 5 or 6 hours? I know that's not technically good sleep and it's, you know, whatever. But whenever you haven't slept in years and you're desperate, you're just like, for the love of God, can I get something? Because, I mean, people do it. I'm not naive to the fact that people have it done and people do it. I'm not saying it's a good thing, but I'm like, gosh darn it, if I could just have money for that reason, that would be really nice right now.
In Vegas, I would hear advertisements on the radio, or you'd see billboards, all over the place, especially near the strip, where they will come out, and it was mobile rehydration services, right?
Yes.
For people who hit it, who partied too hard the night before, you'd have techs or PAs or nurses, whatever, come out and hook you up with IVs to rehydrate you so you can recover quicker to go back out and party, right? So why can't I have a sleep
exactly
technician to come out and do that? I mean, it's.
I know it's
I
not
doubt.
the healthy reason. It's not the logical thing. But you know what? Whenever you're tired and you're exhausted, things like this sound like a really good idea.
Yeah,
so.
they do. They do. So, Advo, what are your thoughts?
I actually came with some facts I'd like to share if you don't mind.
Yeah.
Oh, and you said I was over-prepared.
Yeah, I was going to say, you're prepared. You got facts.
I just wrote mine down. Okay. It's mostly from Mayo, but some is from the NIH.
Okay.
And I want to talk about some things that make us predisposed to insomnia that I didn't know. So, like, a lot of the conditions that I saw were either autoimmune, inflammatory, or nerves oriented that keep people awake at night. And I actually saw that some people can be genetically dispositioned to insomnia. Isn't that weird?
Really?
Mm-hmm. Yes.
I've heard of that.
That's from the NIH, actually. And so I also saw, like, guys love you. Women are more insomnia than men. We have more immune disease. We have more arthritis. We have more MS. And just even being over 60 and stress. Okay, they kept saying stress. I'm like, you're talking to me about stress is stressing me out. So,
stresses me out.
So it also.
But real quick, I think it's
weird how it like. Go ahead.
I was just going to say, it's from the facts that you read and you're sharing, it says that women are more susceptible to painsomnia.
Yes.
Unfortunately, ladies, y'all make up the vast majority of the invisible community, right?
Yes.
Yes. Every study I've read, it's like 70 to 75% of the population is female, or identifies as female. And I look at my followers, out of 8,000 people and bots, it is straight up. TikTok tells me it's 75-25.
Yeah.
Yes.
Which that sends us down a whole other rabbit hole that I don't really want to.
Oh,
we can go down about how women are treated terribly in medical scenarios versus men, and it should be the opposite because you guys are the majority and we're the anyway. Yeah, we're not going to go down that one tonight, but we can, unless you guys want to.
Like even, I remember even my mother and grandmother and great grandmother being up into the middle of the night because autoimmune disease goes that far back in my family history, like 3 or 4 generations back. I was like, I'll never be that way. I don't know why she's up in the middle of freaking night. Go to sleep. You're waking me up. But now I get it. Yeah.
Yeah.
And last thing, and I'll let you go, is they say, stay active and don't nap. No caffeine or nicotine. Don't get in bed except for bedtime. I'm like, those are my favorite things. Naps and caffeine and just rotting in the bed, so I'm like.
But I think a lot of that, for me, the rotting in the bed comes when my pain isn't managed.
Right.
right?
Yes.
And so that's fed by the medical community that either refuses to or feels their hands are tied, or there's a gazillion reasons there, right?
Well, sometimes that's all we can do.
It is.
Mhm.
It is, unfortunately. And I'm not slamming people for doing that. I do that. I'm not
No.
trying to make it sound
Yeah.
like a
I know.
terrible thing. Um, like Amy said today, you have my permission. If you need to stay in bed, please. I want what's ever best for y'all. Um, so I guess the question, like I said, I mean, all the suggestions I could find were just everything that an invisible person does anyway. And whether it's mental health and stress and anxiety
Mm.
alone, right, or bipolarness, whatever the disorder could be, whether it's a chronic illness or whether it's chronic pain, we're doing this stuff. Relaxation techniques, right? A lot of us have tried that. I mean, I hate to admit to my therapist, she taught me that, and I'm using it. And I hate to tell her every time she's right about it, because it works sometimes, right? Start at your toes. Lay in bed, start at your toes. Okay, are my toes hurting? No, they're fine. How about the bottom of my feet? Yes, they're hurting. Is it anything that's abnormal or isn't something that's different from what it was yesterday? No. Okay, so we know that it's normal pain. Up to and work all the way up to the top of my head, right?
Yeah.
It works sometimes, but I hate telling her that it works. Regular sleep schedule. God, who wouldn't love that? Go to bed at 10, get up at 7 in the morning. Life would be good. But before I got hurt, I could do that.
Yeah.
Eat foods that promote sleep. Milk, fatty fish. Like, I have a lot of that laying around. If it doesn't come out of our microwave right now, it's not going in my belly. Kiwis. Who would have thought about kiwis? But where am I going to find kiwis in East Nowhere, Texas? Mattress and pillow. Have a good mattress and pillow. No shit. Right?
Yeah.
And again, combine sleep aids and pain drugs, Tylenol PM, or they have a new one, Simply Sleep caplets, and I would use those but I don't want to put more Tylenol in my system. And unfortunately for me, I'm allergic to melatonin, and I get even worse migraines when I take melatonin. So
I also saw that if you take more medications, the more medications you take, the more likely you are to have that. And dude, I take 15 prescriptions a day. I think a lot of us take medications.
What can somebody start throwing suggestions in the comments? What are the things that you do? Mindy says she has 3 special pillows, none of them work.
Right.
Same here.
My husband put me on a pillow spending freeze because I have been buying pillows because I can't find one that I like. And he's like, you've spent a fortune on pillows this year. He's like, no more pillows. You cannot buy any pillows, because I put a pillow in my cart on Amazon and he saw it and he goes, Amy, no more pillows. And I'm like, but I gotta keep trying. Gotta try.
Gotta keep trying. Somebody even suggested, and the one pillow that I haven't tried yet is I don't want to call it it's like the pregnant pillow. Like for ladies when you're pregnant, there's like a body pillow or something.
A body pillow?
I have one of those.
I mean, I don't know if that works,
30 pillows. Okay, I'm not alone in this. It is hard to find a good pillow. Thank you.
I try to slow down at night. I do some ASMR type stuff, like listening to certain things, certain sounds that have no meaning behind them, but just something to kind of calm me down. Watch, if I can't sleep, I'll try to watch stuff that I'm not interested in.
Right.
To try to calm my brain down. I'll try to watch stuff that that doesn't deal with pain or doesn't deal with politics or doesn't, and that kind of stuff. Dixie says she uses a weighted blanket. Terry said the pregnancy pillow. Those are that, and the mental stuff of just starting at my toes and working up, So that's kind of what I'm doing. I
And I
used
think
to.
it's just, at least for me, you have to have a variety in your toolbox, right? Because something that I did last night probably won't help tonight. So I'm going to have to switch it up. And so finding a lot of things I have found, not, I wouldn't say helps because I still don't sleep much, but when I was looking this stuff up, one of the suggestions was if you can't fall asleep within 20 minutes, get up and go walk around or do something. And I'm like, but I would be walking miles around my house if that was the case. Like, if I leave my bed and go downstairs or do something, my mind, then I'm going to find things to do, type of thing. So, but, I found that like a coloring app on my phone has been relaxing and kind of helpful, which is kind of fun anyway. But side note, like, I didn't think it would be fun. But audiobooks, yes, I found that there's my mom sent me there's this app. I can't remember what it's called. Somebody here will probably know. But it's a sleep type of app that you listen to like people's bedtime stories or like soothing sounds, but it's an app that you turn on at night. Mm-hmm. It's fairly popular. Calm app. Yes. Thank you.
Is that it?
I knew somebody would know. I've heard that's really helpful for people too. I haven't tried that because I think you have to pay for it.
I used to, and it doesn't work anymore. You can go on. I watch a lot of YouTube, especially at night. And if you search on YouTube, rainstorm, like sleep rainstorm, it'll come up with like 12 hours of one video, nothing but rainstorm sounds, right? And that actually helped for a while, but it doesn't do much for me anymore. So we're not coming up with the new ideas. Come on, y'all. I know. I'm just giving each other
because it's like how. I mean,
nobody has the magic bullet tonight.
I have to find whatever I can to distract myself from the pain, no matter what that may be. I may get up and do stuff, and that may tire me out, and maybe stretches and stuff like that maybe get me up and stuff. So like anything I can find to distract myself while I get on the heating pad and icy hot and all that stuff, just I have to stay distracted.
It's almost like disassociation, right?
Yeah.
To get our minds away from the pain or the anxiety, or it's like I said, the ASMR videos for me or sounds. I use that as a distraction to get me away from my thighs hurting or my feet hurting or things like that. I don't think there's obviously not an answer that's going to solve for everybody, right? I really wish.
Try everything.
Susan, personally, I have not been told not to take baths on meds, but I am not a doctor, so don't take my advice. So,
you get drowsy in the bathtub. Sometimes, like a warm bath can make you sleepy. You don't want to fall asleep.
And that might be it. Yeah, I've been told not to take a bath with my toaster. Plugged in.
Some would say that's not a good idea. Others,
that's about it. I guess one last thing, I'll wrap it up, and then I want to get to the OIH because I want to let everybody know it's more strength in numbers crap, right? National surveys say 1 in 4 people have chronic pain. National surveys say 1 in 5 people have trouble sleeping, insomnia, some form of insomnia. So we're not alone in this. There's been some people have suggested maybe doing having a chat channel or a place where we could all go and hang out and talk if you're dealing with it. If that's something that somebody would be interested in, we do have the Discord that's just sitting there. We could open up channels on Discord for that. And on Discord, you could do chat, you could do video, you could video talk with people if you wanted to. That would be an option, but to do that, you just need to let us know so we can set it up and send you an invite to the Discord. Yeah. So I know I bring Discord up a lot. It's just sitting there. We got a lot of traction when they shut TikTok down, and then it kind of all went away. Yeah. So that if you think that would be something, I know Shelly talks about and I need you to send me the page again. There's like a live feed overnight of raccoons that she
Yes.
goes and hangs out and watches, but
Right.
it's full of people with painsomnia that can't,
Yeah.
or just insomnia that can't sleep. And so it's a community, they've already done that, So, so that's just some thoughts. If that's an interest, let me know, or let Dixie know, or Amy know, or Joe know, and we can get this built on Discord. It's free. Don't be afraid of Discord. If you can figure out TikTok, you can figure out Discord. I promise you. I promise you. So, well, we got the topic brought up, and we put sunlight on it, at least, right?
You
We
know,
did that.
I think at the end of the day, you just got to keep trying. You got to throw stuff at the wall and find what sticks for you. Unfortunately, that's not the best answer, but I think you just got to find what's best for you.
Yeah. So, Advo, you have any parting shots of wisdom?
Just keep trying. We're all here together to figure it all out, so we're not alone, and we'll get there.
We'll get there. You're not alone. You're not alone. There's thousands upon us out here. So, all right, Advo, we will talk to you very soon. Thank you for bringing this up so we can get some light on it tonight.
Later.
Okay? See ya. Bye. Obviously, we're not going to get an answer to it tonight because we're all different.
Yeah. And I mean, I think it's one of those things that it's nice to know that you're like, again, I feel like it comes back to this over and over, that you're not alone. You're not the only one dealing with this. There are so many of us who are dealing with this and are just as frustrated. And like, I mean, I know for me, I've tried medications, I've tried over-the-counter stuff, I've tried anything that you could probably think of. And you just have to find what helps you. And it's a trial and error process, and it sucks.
Yeah. I did see somebody have a suggestion, and it was one that I'd never heard before. And it was...
I want to hear more about this.
It was blinking 50 times. Is that what I heard, Snarky?
Yeah, it was... You try to blink 50 times and count your blinks, and I rarely can make it to 50.
Really? I'm gonna try that.
It was not my idea. I don't remember where I heard it, and I tried it, and then I tried it again, and I tried it again, and it's been effective for me.
Really?
I'm gonna do that tonight. I'm gonna try that. I hope it works.
I don't want to overanalyze and try to figure out why it works, but I may have to try that.
Like counting sheep, kind of.
Because I've never heard. I mean, I'm not discounting you. I trust you when you say it works, but I'm at the point that I need sleep. So, but thank you for joining us tonight. I appreciate you for stepping up. I had mentioned opioid-induced hyperalgesia because I was comparing how in a video how excuse me, Painsomnia doesn't have a billing code and doesn't have an official diagnosis, but OIH has an official diagnosis.
Yeah.
And my smart-ass attitude was like, there's billions of people who deal with Painsomnia. Okay, not billions, but lots of people that deal with Painsomnia. And OIH affects 1% of the population that take opioids. Oh, there you are. Now you can see you.
Sorry.
And so they find a way to get a billing code and a diagnosis for something that affects the small part of the population, but something that seems to me could be at least a billing code, a way to bill more and possibly research more to make more money is left to the masses to deal with themselves. And you had left a comment that you have information on OIH, and I purposely didn't ask you what your opinion of it is, okay? Because I want to learn. I think I've kind of probably told you that I have a really difficult. I don't have a good feeling with that diagnosis.
That's
because
fair.
Because of the way my Dr. Pena handled it. He told me every time I saw him that you have opioid-induced hyperalgesia. The more pain meds you take, the more you're going to hurt. And he used that as a sales tool for nerve stimulators steroid shots, and to not, as a reason to justify not helping with my pain, but he didn't have the guts to put it in my medical file that he was treating me for it.
Yeah.
I look at it like if he didn't have the guts to do that, then I probably didn't have it, because he knew the next pain doctor would see it and say, well, what did they do to diagnose you with this? And then they would see that he was just full of it. So if my questions sound mean-spirited, please don't take it that way.
No, I
Okay.
won't take it personally whatsoever.
Because I want to know more about it so I can be better prepared in case something comes up again, and to understand people that have been diagnosed with it, and to be able to better relate to them. Does that make sense?
Absolutely.
Okay. So, opioid-induced hyperalgesia.
Yep.
I'll let you go and explain it from a pharmacist's point of view.
So I'm Lauren. A quick introduction. Yeah, I'm Lauren. I am a clinical pharmacist. I'm certified in pain management, but I also have complex regional pain syndrome type 2. So I live with chronic pain every day. Well, not all day, every day, but every day. Opioid-induced hyperalgesia is we'll just call it OIH to make it simple. It is this phenomenon in science and the opioid world where if you increase the amount of opioid, then you potentially cause or increase pain. So I want to start with where it came from. And the whole idea of it started back in 1994. There was a study done in rats that showed that the more opioid they had, their pain behaviors became worse. Now, with that being said, that study has only been replicated in humans very superficially, and that was in the perioperative setting, so during surgery, and that was with one specific drug called remifentanil. I don't want to say the drug in case.
Yeah.
So it's a very fast on, fast off opioid that they use for very specific surgeries like spine cases, neuro cases, brain cases, some thyroid cases. And again, these results were very superficially replicated. They have not really ever been replicated in the real life setting. So in the 30-ish years that it has been identified, there is still not a clinical tool to help differentiate between OIH and just good old-fashioned tolerance.
Yeah.
So I found a slide. I'm gonna use it to cheat a little bit, but really the only way to differentiate between the two is actually, let me go back. The people that are at risk for OIH, and again, this is a very rare phenomenon. I think that honestly it is overused in the medical community. I think sometimes it is a label for some doctors that are uncomfortable prescribing the necessary amount of pain relief.
I think can I say that some doctors use it as a crutch?
Yes,
as an excuse to not to. Okay, yeah, it's because that
scapegoat.
For whatever reason they'd use it as an excuse. Okay, just wanted to.
And even now, OIH is really only identified in things like case reports. That's how uncommon it is. If it was a super common thing, then they would have been able to do studies on it. And, in 30 years, they haven't been able to do that.
Right.
So people at risk, people that have been on opioids long term and are on high doses. And again, so not everybody gets it. Not everybody even gets tolerance. It's so pain and pain management is so individualized, and people respond to medications differently. So I guess you diagnose it by, clinical symptoms. You can't really test anything. So one way to identify it is if you increase the opioid, does the pain increase? So it's not, and I think with especially the chronic pain community, a lot of times we're chasing our pain. Like we're always behind the ball. At least that's how I feel. I always feel like I get behind my pain. So when you really the differences between OIH and tolerance is with increased doses of opioids, do you have an increased pain threshold? That means like if you stub your toe, does it hurt a lot more than it's supposed to? Or do you start to have like allodynia where like the lightest touch will start to really impact, like that could just throw you into an absolute flare. And another sign is if the pain changes, so the intensity changes, or if your pain used to be throbbing or aching and now it's burning and numb. Again, there's no clinical way to really, there's no tool to figure it out.
At one point, I found like a 4 or 5 question mini checklist for doctors, and I couldn't find it for tonight. And it was somewhere in the NIH, and I couldn't. And it frustrated me because the only one I could remember was the one that you just said, that if you increase the pain meds, then your pain will either change or your pain will increase. And I remember bringing that up to Dr. Israel Pena, formerly of Granbury, Texas, because he cut and ran like a, anyway. And I'm like, dude, let's raise my meds for a month and let's see how bad it gets. And he said, but why? Because it's only going to cause you to hurt more. No, I'm not going to do that.
I disagree with what he did.
Yeah, right. But we know his intentions were obvious in his case. But I think when I really try to give doctors and medical staff the benefit, right? So when people, OIH is such a, I've described it, like I said, the third rail, because it's such a hot topic that if somebody's in with their doctor and the doctor mentions it, my opinion is most people's first reaction is to go off. Just get the hell out of here. You don't know what you're talking about, right? But and that's why I was so glad when you said that you'd be willing to talk about this tonight, because we can get more information, and instead of just flying off the handle, we can say, well, okay, well, let's try it. I've been begging you for the past 6 months to give me a small bump in my pain meds. That will tell us if my pain changes, and then if they automatically refuse, I think you've learned a lot about your doctor. If they automatically refuse without a valid reason,
without explaining the why,
then you have a good thing to say. Maybe it's time. Maybe it's time. So, all right, I didn't mean to interrupt you. I'm sorry to get off into the weeds there.
Well, and that's honestly one of the differentiators between OIH and tolerance is if you do a slight increase, and your pain should decrease. And so really it is about experimentation. And then with OIH, the opposite happens. Like if you taper just a little bit, the pain decreases. And again, I hope people come away with this just understanding how uncommon OIH is. I think it's thrown around a lot. I know I see a lot of TikToks about people saying, well, my doctors don't prescribe opioids because they say it's going to increase my pain. I have a lot of thoughts about that because I don't agree, because it is exceedingly rare.
It's exceeding. Well, I wrote it. Hang on, because actually, according to NIH study I read, it's 0.01% of chronic pain patients actually can fall in the category of coming down with OIH, of being actually fitting a diagnosis for OIH, right? And so if we trust Tylenol, and they say that 1 in 5 people in America qualify as chronic pain patients, that's a huge percentage of the population, and you're at 0.01% of that huge population, right? And we get that doctors are under the pressure of DEA. We get doctors some, and we get doctors that once you hit that 90 MME, even though it's technically not a standard anymore for a lot of doctors, will keep that standard for themselves because they don't want to take a chance and pissing off the EA and everything like that, or their insurance company, or their office manager, or whoever, right? And so they tend to look for the liability. Thank you. So that I think this has become a convenient excuse in certain situations, and I think the reason that you see the TikToks and I see the TikToks about it is because we're in the community that it's targeted to.
Yeah.
Well, and so but in preparing for this tonight, I don't know if I've said this before, but my husband's anesthesia, and I asked him about. This is not the topic. I don't want to change it at all, but I asked him about like the opioid-free surgeries, and he was like, I would never practice opioid-free. I was like, thank you. Anyway, so I just I got his opinion a little bit on this topic and what he saw in the OR, and like in terms of opioids affecting pain and PACU, and he was like, no. He was like, just the one, just the Remy-Schmetnol, again used in certain cases, but otherwise no.
Yeah.
So.
Earlier, you said that in patients that are on a high dose can be susceptible to this. What's your ballpark for a high dose when you say that? I mean, and again, y'all, this is not medical advice. This is not. No. This is just.
Oh, I would say it was, from what I read, it was over 120 MME.
Okay.
And a lot of people that take chronic pain meds aren't even close to that. Like. Okay. I mean, some are, but not a lot aren't. So, I mean, that's, I say a lot, but yeah, I mean, even for me, I've been on chronic pain meds now since I broke my leg 2.5 years ago, and I'm not even a fraction of that. Like, so it is, and here's the thing, if a doctor suspects OIH, I think as educated patients, one, we should know what it is. We should know like how to identify it. We should know what to ask for. So asking like, okay, let's try something different. Let's try to go up just a touch. Or better yet, one of the best tips is trying a different opioid. Like switching it up, doing a little bit of a rotation. Because then the pain should be better controlled. And your pain level shouldn't increase with switching. And if you do have if you do have a beneficial response with switching, it's not OIH.
Yeah.
So
it's not. Terry asked, "Can we get immune to the same pain med after a while?" I don't know if you can get immune. I mean, that's a good question for you. I'm a layman, and I'm going to say, don't know. Everybody's different, but.
It's very, very individualized. I mean, tolerance is a real thing, because sometimes, not everybody, but sometimes you need a bigger dose to deal with the same level of pain, and that is a normal response to being on opioids. Again, there's not even like a percentage of people that become tolerant. Like I couldn't even put a number on that, but instead of immune, you might become tolerant.
Yeah. Or then again, maybe some meds will work better. And again, I don't want to list specifics because I mean we might as well. It's already past the half-hour mark. We've set records.
But
I mean,
let's have a good live here for once.
Because the one that started with P worked much better for me than the one without. That just starts with an O. But due to manufacturing requirements in the United States, I can't get that one that starts with a P. So now I'm on the one that starts with an O. They both work. I just felt I could take less of the first one to get the same benefits I'm getting by taking more of the other one. But that's just me. And like I've been saying on videos lately, we all have different fingerprints. We're all different. We're all going to process not only pain, we're going to process meds, we're going to process life different, right? So, but I want people to have the knowledge that you're sharing that OIH is such a small fraction of the world. And
again, they haven't even duplicated it really in human studies. Like in clinical practice, like we can't put a number on it because we don't even have enough people to study.
yeah,
So,
yeah, but yet they consider it valid,
yeah.
right? And I like to have a conversation with the rats. Let's study their family tree, right?
Well, that's what I had a question about that. What were their like pain signals? Because like obviously you can't ask a rat what's your pain level. So like, did it go into detail on what their pain signals were?
Yeah, actually it did. So their pain stimulus was heat. And so they look at a couple things. Immediately they look at like paw withdraw and like how fast they do it, and then they look at tail flick. And then I swear to God, there's this thing called a rat grimace scale. Who knew? Like the things I learned
No
this
way.
week. So,
What?
I swear to God. And then long term, they look at behavior. So,
Yeah.
feeding, grooming, all the normal people stuff. But
Yeah.
yeah.
I guess I
You know-
never
Who knew?
wanted to get close enough to a rat to see them grimace.
Oh no.
You know, like I
but
never wanted to get that close.
not
personally.
that I want to see rats in pain, but I'd like a T-shirt with the different grimaces, kind of like 6 pictures.
Pain
on the front.
scale in rat
You
form.
know?
Like the Wong Baker scale, the 0 to 10 with rats.
Yeah,
Yeah.
exactly. I mean, I don't want any animal to suffer. I don't. Not for a T-shirt or a
Yeah.
poster. But I think that would be kind of interesting, you know. And you could go in, and doctors could hang it on the wall, and you could go in and point to where you're at that day, right?
Can you imagine if you walked into a doctor's office and there was pictures of rats in pain? I would be like, I'm out of here. This is not my place.
Yep.
Mixed in with nerve stimulators and
Yeah.
pain pumps and everything like that.
But I think if a doctor is going to bring up OIH with you, I think the very first question to ask is, how are we going to do this together?
Yeah.
So that way you're
Right.
on a team.
Yeah.
And then ask what the options are. And if the only option is to taper, then I think being a smart patient is to ask what else? Like, what about switching? What about doing a little bit of an increase? Just, you never know. You never know unless you ask.
So true.
Right. And I think that goes back to which, if anybody's seen any of my lives or my videos, how I preach approaching doctors about increases or changes, or Dr. Mike and I have had some good conversations about pain plans. You know, how uphill single medicine is not always going to be the plan. It's a part of the plan, right? And how people go in and they need to introduce the situation of how they're feeling, how it's impacting their daily life, right? Like earlier we were talking, one of the things they say to deal with painsomnia is establish routines. Well, if you're hurting more, that's going to just destroy that routine, because you're not going to be able to do that type of stuff, right? But that's also the other thing that brings into effect is if people have their doctors that are pushing this and aren't willing to. I could see a doctor bringing it up as a possibility. Hey, there's this study that shows that if I keep giving you more meds, eventually you may start getting more pain. You know, and where the natural response is going to is to go off the hinge. No, and just get kind of like freak out, because we are so terrible. We get so protective of what little we get, right?
Correct.
I think we're
And
always
don't take that away from me. And now you're telling me it's going to cause pain. No, when I know it's working. We need to find ways to have education about what you've been telling people about OIH and the definitions, how small a percentage it is, to where we bite our tongues when we want to fly off the hook and respond with, well, what's the percentage of how many people come down with this? You know, I hear a lot about it online and people talk about it, but really how many people have this? And the answers you're going to get are really going to be the answers of whether you're staying the course with this provider, or whether, if you're able to, it's time to start researching and to see if there's a better option out there somewhere.
I really do think it's an important question to ask. is, do you feel comfortable providing me the level of pain relief that I need?
Yeah.
And if a doctor says no, then it's not the right doctor for you.
Right. 100%.
But I understand, there's a lot with pain management is geography. And people in lesser populated areas, like the studies show that pain management's not great.
Yeah.
So, and that just comes down to options, and it sucks.
Yeah.
Sorry, it's not like a very professional way to say it, but no, it's flat.
No, but it's true. And that's why a lot of us, I mean, I'm driving 2 hours each way, right, to get closer to Dallas or Fort Worth to see a different pain management. Because where I live, it is extremely limited. And unfortunately for a lot of us, it's not just the physical location by itself. It's like the entire hospital system that doctors are associated with are pushing. And, it's crazy that there's not that many pain doctors out there, people that are willing to prescribe to help develop plans for people, because, pain interventionist is one of the fastest growing fields in coming out. Right.
I think the number last year was somewhere around, there were only like 22 or 2,300 board certified pain doctors. Wow. And if you think, so what's 20% of America's population, divide that by 2,200, that's how many patients per pain doctor. And it's insane. It's a big number.
Wow. I didn't realize that. That's crazy.
I think mine is actually an anesthesiologist that specializes in pain and addiction, pain and recovery. It's like Eclipse. The name of the clinic's like Eclipse Pain and Recovery. And, which I always thought was kind of interesting that it's the recovery part's added to it. I'm not under. One day I'll ask him one day.
So I don't know if I've ever said that, but said this before, but I'm actually in recovery myself. I got sober from alcohol 5 years ago. And so that's another part of, not only am I a pharmacist, not only am I a patient or pain patient, but I also have that recovery aspect. So I see the addiction side of it a little bit. So I needed all of those things to make me a better pharmacist, to be able to treat people differently. So, and I find that I approach patients a lot differently than some of my counterparts that have not had some of the same life experiences. I'm
going to ask a question, and all the guests, if you've ever seen my lives, you have the absolute authority to say, get the heck out of here, or I'm not answering, or change the subject. Was it difficult to find a pain specialist or pain doctor or whoever's managing your care? Was it difficult coming in with a SUD history? With were they concerned? Oh my gosh, you have this history with alcohol, and I don't want to give you XYZ because I don't want to trigger and And if you don't have to answer, I'm not trying. I don't want to feel like I'm prying or
I'm open
imposing.
about it. Everybody in my life knows about it. I talk about it very openly. I actually, when I just left a job where I taught medical residents, and I talked about this every single residency class. So I'm an open book. But no, and that's because I was very honest and told them what my plan was. So when I was first prescribed them, I had my sponsor and my husband. I told them that they could hold me accountable anytime. They could do pill counts anytime if they ever thought it became a problem. And I demonstrated, one, I didn't have the same reaction to pain meds that I did to alcohol. Because it's not the physical part, it's the mental part. And they didn't do anything for me besides help my pain. But I demonstrated over time that it was not an issue. And now, no. Now it's not an issue whatsoever.
You know what what I find myself doing? I'll be like, hey Val, I took my pain meds. It's just like the accountability. And because
you forget if you've taken them.
There's nothing wrong with that.
because I've talked to people who, and the reason I asked is I've talked to people who've had histories with alcohol or another substance,
Yeah.
and all they are offered is like Suboxone, and that's it.
Yeah.
And whether it works for pain or not, I'm not going to get into that discussion. But I will say it definitely will have an effect in the things in your mouth and your teeth and your jaw and stuff
Yeah.
like that. You know,
Very much so.
and that's a fear. It's how some people get treated because of their past life experiences. So,
Yeah.
but
I'm sorry, Keith. Maybe it's because because I'm vocal about it, and I didn't ever hide it.
Yeah.
And I was very upfront with them about what my plan was. But no, I very much have seen people with a label of substance use not be offered the same options that I personally was offered, and that hurts me as a pharmacist. That hurts me as a human being. Like, I feel for those people, and I wish I could go and advocate at their appointments for them. So
yeah, because it's not right.
Yeah,
You
no,
know,
it's not. It's not.
And so it just isn't. It isn't. So, does anybody have questions for Snarky or for Amy or for I wish you were my pharmacist. I mean, I could give you horror stories about pharmacists I've had in the past, and I'm sure you hear about them you see TikToks about them, and you're probably cringing, going, you know, because I mean, I have my favorite one was in Vegas at CVS, and the guy's like, I'm not feeling it. You need to try something else. And I'm like, huh? He goes, have you tried extra strength Tylenol?
Oh.
And I've got 7 discs in my back that are blown or deteriorated or gone. Right? I mean, and I'm like, you know, I've been on these meds for like 4 years. Don't you think I would have tried that?
Yeah.
No, it never crossed my mind.
Yeah. And well, you know, we really should try this first. And
I can get you the conversion chart if you want. By the way, I saw a comment.
Oh,
okay, that'd be awesome. Yeah, because I had to ask my doctor anyway. But yeah, that was CVS to me, and that's when I walked out and I called my doctor's office, and I'm like, I'm going to go find another pharmacy, and I went across the street to not even a mom and pop. And she was from Vietnam, and the lady was awesome. And I walked in with my whole medical, that was like 3 or 4 inches folder. And I sat it on the counter and I said, I'd like for you to be my pharmacist. I go, but I get this and I get this and I get this, but I'll get my inhalers from you. I'll get my whatever. If I get the cold, I'll get everything else from you. I go, but if you want to know why I need these meds, here. And she just looked at me and looked at that like I was crazy. She's like, just have your doc send it to me, you know. But I will ask you that you get the rest of your stuff, you know, where you're not just coming to me for your pain meds. And I'm like, heck yeah, you know.
That's fair.
So,
I will say, with my background, I have never worked retail. Like, I think okay, that's a lie. Right after I graduated, I worked at a Walgreens for like 3 months moonlighting just for some extra cash while I was doing my additional training. And it was the most awful place I've ever stepped foot in, and I will never, like, if my options are to work retail or never work again, I'm never working again.
Yeah.
So, I've been a hospital pharmacist my whole career, so I'm on the inpatient side.
Yeah. So I would stick there, because a lot of us patients when our pain meds get cut off, we can be buttheads. I can just.
Well, I mean, I have personally been a straight up fucking asshole to my pain med doctor, because I went I had to go 3 days without, and this was like a year ago, but it's been made to withdraw, and I was pissed. And it's not because I'm addicted to them, but there is a chemical dependence, and that is completely normal.
Yeah.
So,
it would be weird if there wasn't, you know, like if you are taking a high dose narcotic or even a low dose and you stop taking it one day, like you're obviously going to feel the effects. And if you don't feel the effects, I feel like that would be a red flag.
Yeah.
if you didn't feel anything
I
coming
mean,
up.
then you're lucky. Then it just means you're not on a lot, or your
Yeah, that's true.
body's amazing. It doesn't.
Yeah.
Yeah. Mine is not.
No, same.
No.
Yeah.
I've been with mine. Mine started out as a unicorn, and then we had one really bad appointment, and now he's slowly working back up to unicorn.
Mhm.
And I've really given him the benefit of the doubt on that one bed. I went in, I couldn't get my meds due to shortages, and he's like, "Well," first thing out of his mouth, "Well, so you want to try the nerve stimulator then?" And I'm like, "No." Well, so he's like, "You really want me to write your prescription for Suboxone?" "No." "Well, then what do you want?" "How about we find something else around the same MME equivalent?" "Oh yeah, we could try that." I'm
See,
like,
that's a very educated patient. That
Yeah.
probably
You know?
did it get you what you needed?
yeah, it did.
Mhm.
And it was just kind of like, why are we starting out with the nuclear bomb? Let's start. I don't
Yeah,
really
that
want to
sounds
have,
nice.
to have surgery right away. To get through what I've been getting through. So
One thing that I've noticed just in the TikTok world and chronic pain in general is that I don't want to demonize anything. I don't want to demonize Suboxone. I don't want to demonize non-opioid options. I don't want to demonize opioids because it's so, again, individualized to what works.
Mhm.
And so when I see things saying, this is terrible, this is terrible, this is terrible, I feel like lay people, especially non-medical people, they see that and that's what they believe.
Yeah.
And I just, my big thing is pain is a spectrum and you don't know what's going to work unless you try it.
Yeah.
So
yeah, and I think you need to be willing to try, but I also think you need to do your research.
Yeah.
And find ways to question without questioning the doctor. Right? I don't want to question your judgment. I want to question the ability of what XYZ is going to do for me. And it's how I would try. That's how I try to approach it. I always tell him I'm up for about anything, physical therapy, laser, whatever. Let's try all this other stuff before we have to get cut on whether it's a stimulator or whether it's I know they cage more places in my body. Let's try this stuff, non-invasive stuff first for me.
And a stimulator is another option. Like there are a lot of people on TikTok that just demonize this stimulator world, and I know that they don't work for a lot of people, but I am somebody that has had amazing results with my DRG, and so I just wish that we didn't tear down options for people.
Yeah, because everybody's different.
From going after
everybody's very different.
And it's like just because it didn't work for me does not mean it's going to work for anybody.
Exactly.
Like I have different structural issues than you do or whatever, and I think we all have to try stuff. You have to learn for yourself, and whether that's trial and error or you are guinea pig with these new procedures, whatever you're willing to do, I think you have to do that, because otherwise, the option is to not try it and just live in this pain, or you could try these things and maybe get some relief. Like with my stimulator, I just had it reprogrammed a couple months ago and it wasn't working at all. And now it's helping like 10%. So it's like, okay, I will take that. Is it great? Do I love it? No, but it's helping a little. So I'll take it.
Yeah.
I say they're one, I have to have realistic expectations that my pain's never going to be zero. And two, I have to understand that every single thing that I do or take is just a tool. It's not a cure. It's a tool.
Well, I think that's the attitude, though, that I beg people to try to walk in with. And I understand why it's difficult, because it's difficult for me. But I have to address with any doctor or any medical person, I'm not going to get fixed. There is no fix to get me to a zero. And that is one of the hardest realizations I've had to address in my life, right? Because I want to be a zero. I want to be able to do what I used to be able to do. But it's not going to happen. Even if I get a nerve stimulator, or they fuse more places in my back, or they do all that stuff, it's just still gonna be there.
Yeah.
But that's why I stress on people to just go in and be willing to try stuff, and find what you can get that will increase your quality of life.
Yeah.
And for y'all, it's a nerve stimulator. For some, it is Suboxone. For some, it's a pain pump. For some, it's PT. I mean, don't go in and beat your doctor up because it'll make your quality of life better, because there's consequences, right? But at the same time, I think we need to come in with realistic goals. Talk with people who definitely expect to be at a 1 or a 0 and are disappointed or mad at their docs because they won't get them there. And, well, there you go. I don't think that's your doc's fault. I think we just have to go for the quality of life, is what it is.
I think one last thing I wanted to leave people with is that you are 100% in your patient right to ask the why. Can you please explain why you're making this decision or making this recommendation? Like, where is this information coming from? Rather than, I think sometimes, especially when I hear that whole, my doctor doesn't prescribe because it'll cause pain. Explain to me why. Explain to me what you've seen. Explain to me where you're getting your information. And you can do it in a pleasant, nice way and have a conversation, but 100% okay to do that.
Yeah, I love that.
Yeah, it's a great way to leave it, because it's our life, and asking why shouldn't be a reason for your doctor to go ballistic.
No, and if they do, they're shitty doctors.
If they do, that's a reason to.
Yeah,
that's your sign to make sure you have a copy of your records.
I don't. Slated Fury. It's the conversation was. It's okay to ask your doctor why.
Yeah. So, well, cool beans. Thank you for your time tonight.
Thank you.
I appreciate you.
Learned so much about OIH, and so thank you for sharing your opinion and your medical knowledge, because I feel like even though I feel like we kind of know things about the pain community, it's nice to hear from a medical professional your opinion and all that stuff. So thank you so much.
Yep. So Keith, I agree with you. The summary is I agree with you about OIH.
Yeah. So, well, have a great night. We're gonna do victories. If you want to hang around, I'm gonna disconnect from here. If you want to just stick around,
please do.
See if we have some victories, and we appreciate you and your opinion. Thank you.
Bye, everybody. Thank you.
Thank you. All right, we're gonna do this. I feel smarter.
That was awesome.
I feel a lot smarter.
That was awesome. I feel like that has been like the best conversation that we've had in a really long time about a really good topic. That was really good. I like that a lot.
I like that too. And again, it's information that I want people to be able to take in. So when and if their doc brings it up, we can have a conversation instead of a yelling match.
And it always goes back to being the educated patient. Like she said, ask why. Have them explain if you don't understand, or if they're not wanting to do kind of what you're wanting to do, or just being more educated on this topic, because the more we know, the better.
Yeah. And, if your doctor goes off because you're asking, the question that set Dr. Pena off is, what do you see in my behavior that makes you think I have OIH?
Yeah.
And oh my God, it's like I set fire to his office, right? And to me, that was and I didn't scream it. I didn't say, all right, motherfucker, what makes you think I'm an
Yeah.
I just literally said that. And it just set him off. So, but I also understand, we also pretty flippantly just threw around, go get another doctor. I realized that getting another doctor is not as easy as it states, and in some cases, some people can't. And I feel for people that can't, and we need to find better solutions for folks that can't. So, you want to do some victories?
Let's do
Does
some
anybody
victories.
have victories
I
tonight?
need some good
Tell
things.
me
Give me
somebody has victories. Was it a shower? Was it a good doctor's appointment? Did you find your unicorn? Did you what? Something.
give
Tell
me the
me.
good
Did you
vibes. Tell me the good things. Tell me all the things.
Sarah cleaned out the pantry and the fridge. Hallelujah. Leslie worked 2 days in a row and a flare. Not a victory, but determination. Hell yeah.
But you're
There
out
you
of the
go.
flare now. So that's good.
Sarah, I'm sorry you got nada.
You know
Kelsey, they
what? It's
finally
okay.
approved your
Next week.
PT. Hallelujah. Oh no, Lisa, I'm sorry about your horrible appointment. I've had those. Those are not good.
You will have a
Um,
victory next week. I know it.
Susan, I survived no electricity for most of the day. That's big right
Love
there.
that. Hate
I'd have
that
to
for
be sitting
you.
in my
But
car so my phone could charge. Um, what's happened here? I swept and mopped the house 2 days ago.
yes, you did.
I'm still paying the price. But I did get that accomplished, and that was huge, you know.
That's awesome.
So that was my victory for the week right there. I got Valerie to doctor's appointments on time. That was another victory for me.
Huge victory.
I canceled my CT scan and abdominal scans this week, though. It's a whole other.
That's next. We can do that later.
Yeah, we can do that later.
Yeah.
We did have a big victory. I'm meeting the contractor we finally have power at the property that we bought. That's a huge victory. And I'm meeting the contractor out there this week so we can get water and power put to the places we need it. Not just to the front and back of the property, but to where we need it. So we can we only started this around Thanksgiving, right? And we're almost into March. So,
you're getting there.
God bless small town living. You know, take the whole month of December off for Christmas and can't work in January because, we're still recovering from New Year's Eve. But so we have some light at the end of the tunnel where we can get this thing on wheels, move to our own dirt, and have whole new sets of problems there, and but I'm looking forward to that. Ricky had 2 negative doctor appointments with pain. At least yesterday was a little bit better, right?
We will take the small. Any win is a win around here. Thank
you for saving your puppy there, Annabeth. That is awesome. Some of us have had just a little victories. That's awesome. Fixed my bike finally, cost a day of downtime, but worth it. There you go. See, I love this community because stuff like this, people who are normals don't get it.
Yeah.
Don't get it. And we do, and we are here. Susan said, I made your last 2 lives. I'll take that as a victory for sure. Thanks. And you're still alive. We didn't getting bored of that.
Thanks for hanging out with us.
Great victories. Do you have tea, Miss Amy? I know you've been sick.
I do, but I'll save it for next week because I gotta go take my pain meds.
All right.
So I'll save it for next week. I'll keep you guys on the hook.
What was it? Was it as good as stabbing your son with a letter opener at the store?
I fear not, but it does have to do with the guy that SWAT got called on.
Oh. Wow. Okay. Well,
I'll write it down so I don't forget next week.
All right. Parting shots, parting words of wisdom from the Brain Trust. That's you.
Oh my gosh. Well, again, I'm going to say this every week. Thank you guys for being here. You guys bring us so much joy, and on the hard days, this community is what gets us through. So thank you guys for being here tonight. I love you all so much. And I hope everybody has a better week, and that if you didn't have a victory to share tonight, that next week you are going to have a victory. Because I know next week I'm going to have a victory to share. I just know it. So
there you go.
And I am going to leave it hanging on my tea. Sorry.
Thank y'all for tonight. And thank you, Lauren, Starkey Pharmacist, for being here tonight. That was good. Advo, Karen, thank you for your time and your research and making it through those NIH studies to bring us all the information. I wish we could have come up with the answer for Painsomnia, but unfortunately, everybody's going to be different. These lives mean the world to me. I'm beat. I'm guessing 65 masks tonight, but I wanted to be here so bad for you guys because what you do for me and how you guys love and support everybody in the invisible community. So we will see you guys soon. And if you need something, message me, email me, keithcpp@gmail.com, and we will talk to you guys later. I'll be safe. I'll see you. Bye.
Bye.